Good evening, friends. I'm coming back after a long time, but I thought this is a very, very important topic that I must discuss with the PGs, especially if anybody asks you what are the three important diseases, medical disorders that you come across in obstetrics. Number one is hypertensive disorders. Number two is hyperglycemic disorders. And number three is, of course, anemia. No PG can afford to say that I don't want to know these topics well, or you cannot say in the exams, I'm confused, I have forgotten, I don't know much, and things like that. Because these are not only important from the theoretical aspect, these are the cases that you see day in and day out, whether it is in India or in the first world countries, anywhere. One must know the complete pathophysiology, pathology, the predictions, prevention, and the management of these three diseases. So in a series of lectures, because I cannot complete everything in one lecture, so straight away I have given it as part one, where today I'll be discussing only pathophysiology and pathogenesis of preeclampsia. And tomorrow and day after tomorrow, I'll be talking about prediction and prevention, and finally management. Right from the day I started teaching preeclampsia, I have been telling that this is a mysterious disease, and whoever finds out the exact etiology of preeclampsia will get a Nobel Prize. And I challenge this to many of my students, in fact, all of my students. But till today, the mystery has not been solved. What I'm going to talk today is based on ACOG Practice Bulletin number 222, Gestational Hypertension and Preeclampsia, published in Obstetrics and Gynecology 2020. It's a very recent updated version of the lecture. Before we go further, we must know the classification. This is a standard thing in any topic. Preeclampsia, or I would rather call it hypertensive disorders of pregnancy. It has gone through many nomenclatures. In fact, pregnancy-induced hypertension, preeclampsia, or toxemia of pregnancy, and so many things. But the latest is hypertensive disorders of pregnancy, and the classification is as follows. Number one, it has not changed, I must tell you that. Gestational hypertension. Number two, preeclampsia, eclampsia. And number three is chronic hypertension. And then chronic hypertension with superimposed preeclampsia, eclampsia. I'm going to explain each one of them in the next slide. When the absolute blood pressure is 140/90 millimeters of mercury during pregnancy, it is called gestational hypertension. You may wonder how you got this magical number of 140/90. They have studied thousands and thousands of women having hypertension, and when they plotted it against the fetal outcome or the fetal effect, the cross section was at 90 diastolic and probably 140 systolic. The maternal complications and the fetal complications they started deteriorating at this juncture. That's why 140/90 as an absolute figure is considered gestational hypertension. When I studied undergraduate, even in the early days of my post-graduation and the lecturership, I used to teach or a rise of 30/15 blood pressure or a mean arterial pressure of 105 also are considered gestational hypertension. Well, they have been deleted nowadays. They are no longer used. It's only 140/90. But let me tell you that rise of 30/15 is a very, very useful indicator. Me as well as Dr. Pratap, we both of us teach that. Because let us say a patient's blood pressure was 100/, let's say, 60. Most of the ladies have that kind of a blood pressure. We see that in the first trimester. Let us say in the second trimester or in third, they go up to 130 by 80. It looks normal, but you notice that there is a rise of 30 systolic and a rise of 20 diastolic, which means that she is deteriorating in terms of hypertension. And that is the lady which may later have what is called late onset preeclampsia, one which is after 34 weeks. And that can be dangerous. All late onsets are dangerous. They catch you unawares. We also have seen early onset FGR and late onset FGR. Late onset FGR is most dangerous because you are caught unawares. You have got no time to actually diagnose that patient and manage. Whereas an early onset FGR is bad, agreed, but you are alerted right in the beginning and you're very careful and you follow that patient very well. So these are the late onset ones which will embolden you right in the beginning of the pregnancy and throughout the pregnancy. But last minute, they are the ones who will have a lot of calamities, and no patient and patient party will excuse you for missing that. That is why it is important to also remember a rise of 30 by 15. To this, if you add proteinuria of more than 300 milligrams per liter. Now, this was the only condition to call it preeclampsia, but this latest article has told us that it's not just proteinuria equal to or more than 300 milligram per liter. If there is a decrease of platelets less than 10 to the power of 5 microliters, or serum creatinine more than 1.1 milligrams per dl, or a doubled AST and ALT, or pulmonary edema, it doesn't end there. One more, or headache, or visual symptoms. Now, any one of them, it need not be all of them. And sometimes there may not be proteinuria to the extent of 300 milligrams per liter, but she may be already having some headache and visual symptoms, even at 140 by 90 millimeters of mercury. This has been observed. That's exactly why the scope of definition of preeclampsia, PE, has been extended to have any one of them, or couple of them, 3, 4 of them, or all of them. Earlier, we used to consider headache and visual symptom as a sign of imminent eclampsia only, but that is no more. So also pulmonary edema and double AST, ALT, or serum creatinine. They all come under preeclampsia. We have to be vigilant thereafter. To this, if you add convulsions, it becomes eclampsia. Now, all of them can be in the backdrop of chronic hypertension, which means chronic hypertension superimposed with preeclampsia or eclampsia. I hope I am very clear so far. Once we are clear about this, let's move towards pathogenesis and pathophysiology. If I have to summarize whole preeclampsia in one slide, this is the slide. Because there's a huge difference between hypertension and preeclampsia. Hypertension is only one of the many manifestations of preeclampsia, as you saw it in the previous slide. In fact, there's an entity called atypical preeclampsia, where you may not see hypertension at all, but you may see all other manifestations of preeclampsia, including FGR, including convulsions, raised AST, ALT, creatinine, everything. What more? Earlier, we used to say preeclampsia definition, all that what I explained, had a gestational cutoff that is only after 20 weeks, no more. Atypical preeclampsia, you can see the problems even before 20 weeks, when the BP was normal. For example, a patient may abort. She may have a miscarriage before 20 weeks, but the cause of that could be preeclampsia, but you have not yet seen hypertension in her. If the pregnancy had progressed, probably you could have seen hypertension. What it means is that the pathophysiology starts cooking. I use the word cooking because most of the pregnancy related problems, that means the problems which are only because she became pregnant, start showing up after 20 weeks. This is a general formula that I always teach undergraduates and postgraduates. But what is happening in the first 20 weeks is the pathology or pathophysiology or pathogenesis. So these 20 weeks are used for the formation or cooking of the pathology. And once that is cooked properly, the patient will have clinical manifestation of the disease. I hope I'm clear. So this slide will totally tell you what is preeclampsia. Preeclampsia is not just about hypertension only. It is a multi-system progressive disorder. That is the difference between an hypertension that you see in a non-pregnant lady or even men for that matter, wherein we have seen these men and women will live years together with hypertension, taking a tablet or two per day. But a lady with preeclampsia can deteriorate in a span of not even 9 months, less than that, within months, within weeks. And she can even die of preeclampsia. So I want to clarify again and again, or I can't overemphasize that preeclampsia is not just hypertension, though the name is given hypertensive disorders of pregnancy to encompass all the problems that will show as hypertension. But when you say it is preeclampsia, you must understand that it is something different. It's a multi-system progressive disorder. And that's why we need to understand the pathology properly. We have to understand the pathogenesis properly, though we have not yet understood the pinpoint cause. Soon we may find that out as well. So let me first deal with pathogenesis. Can you decipher this? Yes, it is as complex as that. When I press next, you will see whole lot of things: diabetes, obesity, antiphospholipid syndrome, maternal infections, dyslipidemia. It is related to even donor sperm IUI. It may be related to primary dyslipidemia, chronic hypertension, MTHFR mutation. It may be factor V lead mutation. It may be primiparity, or it may be deficiency of thrombin. It may be a renal disease. It may be because of twins where you see exaggerated hypertension. It may be molar gestation. Whatever it is a complex disorder. Let us go slowly and try to understand this. As early as 2001, Robert J.M. Redman gave a beautiful explanation of this, and it holds still today. And I was so impressed after reading this particular article. And later I kept on following up Roberts and Redman. They have not changed much, and they have beautifully explained. It's a multi-system disease with pathophysiological changes secondary to reduced organ perfusion. So in every single organ, there is reduced organ perfusion. So it's a multi-system disease. When there is reduced organ perfusion in multiple organs, which means it's a vascular disease. It affects the vasculature everywhere. There is reduced organ perfusion, and the main cause of that Number one is vasospasm. Number two is vascular occlusion. Usually when I teach undergraduates, I tell them the entire subject has to be understood by one word or maximum two. That's the concept of microchip understanding. And everything will open up itself. And today, let me tell you, if you have to remember one word about preeclampsia class, and that is vasospasm. If you have to remember two words, then it will be vascular occlusion and vasospasm. This will explain all the pathology in all the organs. Even if I stop the class now, right now, you can just sit quietly and understand the effect of this vasospasm and vascular occlusion in the brain, in the lungs, in the liver, in the kidney, and in the periphery. It's very, very simple, as simple as that. But what we need to understand is why there is vasospasm. It is secondary to increased sensitivity of the vasculature. All of us have vasculature, but all of us will not have vasospasm. There's an increased sensitivity in these women to usual circulating pressures. That is the thing. The pressures are same in that lady also, but she has increased sensitivity. What are these pressures? Thromboxane, angiotensin 2, endothelin 1. These are the pressures which will have an exaggerated effect on the vasculature of the lady who is destined to develop preeclampsia. What's the reason for vascular occlusion? Secondary to activation of coagulation cascade. In these ladies, there is activation of coagulation cascade, and that is due to secretion of substances by damaged or activated endothelial cells that promote coagulation. All of us know this. Basic coagulation, we have learned it in first MBBS physiology. Either it is platelet aggregation or aggregation because of the damage of the endothelial cells, and a whole lot of chain will be set. That's how it is. So, pathogenesis, what we know so far is that preeclampsia is a two-stage disease. In stage 1, which is preclinical, which is that before 20 weeks, what I say cooking time, is reduced placental perfusion. Secondary to vasospasm and vascular occlusion. Now, stage 2 is a clinical entity, which is usually seen after 20 weeks, is consequent maternal syndrome characterized by endothelial dysfunction. Now, what is the central or the starting point in pathogenesis? Yes, there is reduced placental perfusion, which is secondary to vasospasm and vascular occlusion, all right. And the clinical syndrome is characterized by endothelial dysfunction, all right. But who kickstarts this? What is the starting point? Right from Williams 1977 till today, the only explanations that we see and the only culprit of all this is placenta. Why we say that it is placenta? Why it is not fetus? Why it is not mother? The explanation is beautiful. Molar pregnancy without fetus can cause preeclampsia. It's another matter that nowadays we don't allow molar pregnancy to go beyond even first trimester, or they get aborted. And all of us have been told from undergraduate days that preeclampsia is only after 20 weeks. That's what I am trying to emphasize and impress upon all of you. Preeclampsia is not after 20 weeks. It starts right from the beginning of the pregnancy. The clinical manifestations are seen after 20 weeks, but sometimes before that in the form of abortion, which is called atypical preeclampsia. And that's why even in a molar pregnancy where there is no fetus, she can have a whole lot of pathology of preeclampsia. Another point to say that placenta is the culprit. Delivery after the fetus alone is not enough for resolution of preeclampsia. You have to deliver the placenta as well. These 2 points finger at placenta as the central starting point. Placenta in normal pregnancy, there is a tumor-like extravillous trophoblast invasion into maternal spiral arteries. These trophoblasts have a tumor-like, what you call, mentality or a instinct to go and invade. Normally, cancerous cells go and invade. But these are not cancerous cells, but they have a tendency to behave like one, and they go and invade the maternal spiral arteries, right? Like that. And they become endovascular trophoblasts, partially replacing maternal endothelium. So when they go and invade the intima, in fact, the elastic layer of the vessels wall, intima, what we say, they become endovascular trophoblasts, partially replacing maternal endothelium. And the vessels become hybrid vessels. Some part is lined by maternal endothelium, and some parts are lined by fetal cells. What are those fetal cells? Extravillous trophoblastic cells. Now what happens? In preeclampsia, there is inadequate invasion by extravillous trophoblasts. Some people have now challenged this, but it's not been challenged inconclusively. So I would still go with this theory only, unless it is proven. Anyway, it's an evolving subject. It may change in coming years also. But as of today, we still hold on with this theory that there is inadequate invasion by extravillous trophoblasts, which normally happens in a normal pregnancy. As a result, absent or deficient remodeling of the spiral arteries necessary for adequate placental perfusion. What is the meaning of this? When the extravillous trophoblasts go and attack or invade the elastic layer of the vascular wall, they break down the vascular wall elasticity, and the vessels are rendered always dilated. Vessels are rendered always dilated. And that is in favor of pregnancy. And that is called remodeling of the vessels. When the vessels are always dilated, the baby gets enough and more blood supply. What a wonderful thing that the body does. During pregnancy, everything is pro-fetus. Mother is pro-fetus. Maternal system is pro-fetus. And so much so the vessels also remodel themselves, always dilated to help the baby. But in preeclampsia, that is absent. So the vessels are still spasmodic. The elastic membrane is intact. And not only spasmodic, in these ladies, they are hypersensitive to the usual or normal vasopressors. So to summarize so far, we have to understand this slowly. That's why I summarize at every level. What we have understood is there is inadequate invasion by extravillous trophoblasts of the vessels, deficient remodeling of the spiral arteries as a result, and hence there will be vasospasm and vascular occlusion, because they go and damage the endothelium. And when the endothelium is damaged, there is kick-starting of the coagulation process and vascular occlusion will happen. So one hand, there is vasospasm, other hand, there is vascular occlusion. Net result is there will be decreased blood flow. Vasospasm is due to increased sensitivity to thromboxane, angiotensin 2, and endothelin 1. And vascular occlusion is because of activation of coagulation due to damaged endothelial cells due to invasion by the extravillous trophoblasts. Net result, reduced placental perfusion. So what we don't know So far, what we know, there is reduced placental perfusion because of vasospasm, vascular occlusion, and as a result of reduced placental perfusion, there is, total reduced perfusion in different organs. What we do not know is that why not all women with reduced placental perfusion have preeclampsia? Because this pathology is also seen in patients who would develop only FGR or those who develop only preterm labor. In other words, the pathology, pathophysiology, and pathogenesis of three conditions is same. That is preeclampsia, FGR, and preterm labor. We can say they are not cousins, but they are siblings. But some ladies will have all three of them. Some ladies will have preeclampsia and FGR. Some ladies may have only preeclampsia. Some ladies may have only FGR. Some ladies may have only preterm labor. So what makes a lady to have preeclampsia with the given reduced placental perfusion? Perhaps reduced placental perfusion must interact with maternal risk factors. That's where the risk factors also come into play. What are these maternal risk factors? Number one, genetically inherited. We know this very well. Preeclampsia runs in families. Mother has it, daughter may have it. So it is an inherited problem. Factors associated with endothelial dysfunction. In addition to inheritance, there should be factors in that lady which are associated with endothelial dysfunction as well, because that is the second part of it. Number three, it is related to immune-mediated cytotrophoblastic cell invasion. We have understood that there is no invasion, but why there is no invasion in certain ladies only? Let us take up one by one. Genetically inherited factors. There is defective HLA-G expression in these ladies who are destined to become preeclamptic. It contributes to inadequate trophoblastic invasion. Probably this is the reason why in these ladies carrying defective HLA-G, there will be inadequate trophoblastic invasion. Trophoblasts become vulnerable to attack by peripheral natural killer cells. PNK means peripheral natural killer cells. Their invasion is not facilitated by uterine natural killer cells, means decidual natural killer cells. So double whammy. First, trophoblasts are vulnerable to attack by peripheral natural killer cells. Second, their invasion is not facilitated by uterine natural killer cells because of this defective gene. DNA G may act as NK cells, whether they are friends or foes. They may act as friends or foes depending upon which population of NK cells are dominant. Now I have to tell you a little bit about which type of NK cells. There are two types of NK cells. Number one is CD56 bright NK cells, which are uterine NK cells, and DNK means decidual NK cells. The other one is dull, that is CD56 dim. As you can see, the color also is little dim. And these are PNK means peripheral natural killer cells, and CNK means cytoplasmic natural killer cells. The one which are bright are less cytotoxic. One which are dim, peripheral, they are cytotoxic. So the first variety will secrete facilitatory cytokines, that is interleukin 8 and 10, and angiogenic factors VEGF and PIGF, whereas the other one will not secrete them. So because they secrete this, they induce and support invasion of trophoblasts. But here they are cytotoxic. They secrete interleukins which are dangerous, and they will not support the invasion of trophoblasts. So trophoblasts lacking HLA-G expression, not facilitated by uterine NK cells and attacked by PNK, the problem of non-invasion occurs. Second, genetically inherited problems. Mother with AA type of genotype, AA batteries. they are lacking most of the activating killer cell immunoglobulin receptors. Plus, fetus, if these mothers get a fetus with HLA-C2 phenotype, these are the things which PGs have to remember. We don't usually remember this once we start practicing, but you need to remember to write a good answer in the exams. Seminal priming, this is what we have to really understand clearly. If they change the partner, with every new partner, they'll get preeclampsia. But it doesn't mean that if a lady has preeclampsia, second or third time pregnancy, that she has changed the partners. 25% of preeclampsia patients have recurrence. But sometimes what happens, the same lady, she had, let's say, preeclampsia, and then they use condoms, and she's not exposed to the semen for a long, long time. And then they decide to become pregnant. She decides to become pregnant again. That's the time it's almost like a new partner for her because her immunological memory has been lost. So here comes previous exposure to paternal serum plays a protective role against preeclampsia. But if it is paternal, alloantigens play a pivotal role in embryonic cells' interaction with maternal immune system. So if they don't interact for a long time, then they will be considered as foreign antigens. Endothelial cells, they mediate vasomotor tone, we all know that, and they regulate nutrient exchange as well, and they modulate inflammatory process and play a primary role in angiogenesis. So the factors that are associated with endothelial dysfunction is the second major factor, maternal risk factor. These are the patients who have chronic hypertension, diabetes, and insulin resistance. So severity of hypertension and diabetes is directly correlated with the risk of developing preeclampsia. We all know this. This is a part and parcel of dyslipidemia syndrome. Renal disease. These patients who have got endothelial dysfunction, they also develop renal disease, dyslipidemia, and various thrombophilias. So that's where, if you saw in that complex picture which I showed, there can be antiphospholipid syndrome, protein C or S deficiency, antithrombin deficiency, factor V Leiden mutations. These are the patients with APLA syndrome, what we call, and familial hemophilias. They are the patients who will develop clinical manifestation in the form of preeclampsia, preterm labor, and FGR. Finally, obesity and androgen excess. So they also have urinary tract infection, periodontal disease, which are again like associated factors with preeclampsia. Now I come to the third factor that is related to immune mediation, invasion, and angiogenesis. Primiparity. I just explained a little bit in the first risk factor. Here I explain further. Primipaternity, condom use. Let me explain again if you didn't understand earlier. The maternal MHC class 1 and class 2 tolerance to paternal MHC 1 and 2 protein occurs after long exposure to paternal seminal fluid. So if the person has been using condoms, this exposure is lost. And after a few years, if there is a fresh exposure, it will be considered like a fresh antigen or a fresh partner. As we know that preeclampsia is very common in primiparity or primigravida, what we say in India, and primipaternity, that means the first partner. So if a person has been using condom for a long time, the same husband will be considered by the body or immune system like a new husband or a new exposure. IUI, IVF with donor gametes, they meet with the same consequence because it's a fresh and new exposure to a new antigen. Twins, for some reason, they will have immunomediated invasion and angiogenesis problem. Same thing happens in molar pregnancy as well. So to summarize at this level, the risk factors such as genetic, endothelial, and immunological, the three factors that I said. Genetic means defective HLA-G attacked by PNK cells, and mother having HLA-AA battery, plus fetus having HLA-C2. Endothelial means those women who are exposed to hypertension, diabetes, obesity, dyslipidemia, thrombophilias, and infection. Immunologically means primary parity, paternity, donor IVF, IVF, twin, or molar, where the immunological systems are just gone for a spin. With this, there is inadequate invasion by extravillous trophoblast, and that will make the deficient remodeling of the spiral arteries, which will give rise to vasospasm and vascular occlusion. Vasospasm is basically because of increased sensitivity to thromboxane, angiotensin II, endothelin 1. Occlusion is because of activation of the coagulation due to damaged endothelial cells. Net result is reduced placental perfusion. But we have to unite them. We have understood reduced placental perfusion. We have understood there is endothelial dysfunction. What is the connection now? Who unites them? Reduced placental perfusion with a clinical syndrome because of endothelial dysfunction. The linking factor is probably the oxidative stress. This is called unifying theory. Now, this oxidative stress in the presence of maternal risk factors will give rise to preeclampsia. That is proven by this. Sera of women with preeclampsia had markedly reduced antioxidant activity. They give a hypothesis and they prove the hypothesis. That's the beauty of science. Oxidative stress in placenta releases SFLT1. Now everything makes sense. This is what is being evaluated in the prediction of preeclampsia, which is soluble FMS like tyrosine kinase, which antagonizes angiogenic factors like VEGF and placental GF, antagonizes. Then soluble endoglin. This is what we do in our dual testing, along with dual testing to predict preeclampsia. I will talk more about it tomorrow, maybe. Then pro-inflammatory cytokines, trophoblast debris. So when there is oxidative stress, these things are secreted. And that will connect reduced placental perfusion with endothelial damage, leading to inflammatory milieu, causes generalized endothelial dysfunction. Most plausible explanation, hence, each clinical manifestation of preeclampsia is the result of endothelial dysfunction at various key organs. You name a clinical manifestation: edema, hypertension, reduced placental perfusion, leading on to endothelial dysfunction. Preeclampsia, hence, should be redefined as a systemic disease of maternal endothelial cell dysfunction. Wonderful. Let me end with this particular flowchart. Pathogenesis and pathophysiology. It has got a genetic basic, immunological basis, and pro-inflammatory basis, which will lead to faulty placentation, inadequate trophoblastic invasion, leading on to reduced placental perfusion. Now, reduced placental perfusion